Welcome back to the final panel discussion for AAKP's 7th Annual Policy Summit. We're closing today's programs with our most important issue, kidney disease screening, implications and costs to people, taxpayers, employers, and disease prevention efforts if the federal government fails to embrace kidney disease screening. Joining us today, we have Dr. Barry Smith, President of the Dreyfus Health Policy and Research, Rise Up New York, and a member of AAKP's National Board of Directors. Alongside him, we have Tamara Windau-Melmer, Director of Advocacy Relations for Cardiovascular and Renal at Bayer Pharmaceuticals. Early kidney detection, identification, and treatment is a very timely issue, one that kidney professionals and kidney patients have raised as an unmet need to federal officials for over the past 2 decades. As we speak, the U.S. Preventative Services Task Force, a body of medical professionals appointed directly by the Secretary of the U.S. Department of Health and Human Services, is debating whether or not they will recommend kidney disease screening for U.S. communities known to be at high risk. It is important to note that the current Secretary of HHS, Xavier Becerra, has not appointed one kidney expert to the U.S. PSTF. In fact, we have more kidney experts here today at the National Press Club than there on the U.S. PSTF. Think about that. 5 years after the bipartisan executive order of advancing American kidney health that call for greater upstream detection, intervention, and management of kidney disease, a federally appointed body of experts is still debating whether kidney disease screening is necessary. AAKP and our kidney allies knows what should be done, but we are not certain what will be done by this HHS task force. I'd like to turn it over to Dr. Smith to share his perspective, which is not only in favor of early screening, but also Dr. Smith believes passionately in community-based health solutions, which ties in very closely with early disease detection and intervention. Dr. Smith, I turn it over to you for your thoughts.
Well, we're turning things upside down, and I give you greetings from Brooklyn. Forget about it, as we would normally say. So we're going to talk about what's wrong with the U.S. healthcare system, and then come back to relate that to screening for kidney disease. So what's wrong? Well, the Commonwealth Fund, just about a month ago, released a report, Mirror, Mirror 2024, which says that the U.S. healthcare system, compared to that of 9 other economically peer countries, is the worst of all. We spend more and we get less out of it. Why is that? Well, you can look at a couple of things, because you can say, well, we can talk about it, but is it really different? Is life expectancy different? Well, the U.S. is on the wrong course. Our life expectancy is worse than any of these other countries that are economically peer. And you can see that on the graph. And we tend to talk about COVID, but it's not about COVID. This started in 1980. 2 points that sort of, I think, dramatize this. Between 1980 and 2019, 335 million fewer years of life would have been lost in the U.S. if our mortality rate was the same as that of other nations. In the COVID years, 2.1 million fewer people would have died if our mortality rate was the same as these other countries, Europe, Asia. And if you look at non-COVID mortality rates more contemporaneously, we see that, and you can see from the top 2 lines on one side, diabetes and hypertension are increasingly dramatically in the United States. Why is that? Kidney disease is on the rise too, but it isn't as dramatic as these other things. And then we have other problems too, with violence and things that we don't know how to deal with, and we're not dealing with very effectively. Oh, we say, okay, that's all right, but we're shining inequity, right? Well, the bottom line here is that we come out at the bottom of that also. So when you compare to these other countries, we're not doing what we should. And you can look, there are two things on this slide. One is maternal mortality. We're number 26th in the world in maternal mortality. And for a black woman who has a child, her mortality rate is 3 times what it is for a white woman. This is not a system that's working right. And then you turn to kidney disease, we're talking about 3 times as many people of color sitting in dialysis chairs. I built one in Brooklyn some years ago, and I immediately saw that 60% of those people should never have gotten to that point. And to me, that's wrong. So what can we do? I think we need a different model of healthcare, and AAKP to me represents the community in action, and we need much more of that taking place. The repair shop, which we have, is excellent. It's terrific. And if you compare healthcare delivery in the United States to those other 9 economically peer countries, we're number 2, which isn't so bad. But we come out so badly in everything else, we end up being number 10. So waiting until we're at the repair shop, which is when we fix things, and we've been talking a lot about that, and very important issues, we're always going to need it. But what do? Well, I think we have tremendous opportunities to do screening. Take, for example, the number of Americans over 20 years of age, because one of the big things that happened recently over those last 40, 50 years has been that the age at which people are getting chronic illness has dropped down. So you're talking about people 20 to 40 years of age, the working force, the people who are the heart of our economy, they're getting sick, and that shouldn't be happening. So you can look at the numbers here, and there's the paper that was just published this week in Lancet, says that 3/4 of Americans, that's over 200 million people, are either overweight or obese by BMI, and we know now that that's an old index. You don't want to talk about body roundness, but we won't get into that today. So I think what we can do is to have the community take much more responsibility for healthcare. We can get in the housing projects or housing developments in East New York, we can have teams of people who are doing screening and education. We can cut back the number of people who are getting these chronic illnesses. And look at the difference. Dialysis, and you can have different figures here, you don't prevent the disease. It's $90,000 a year for somebody sitting in a chair in the unit I built on Linden Boulevard in East New York. Kidney transplant is fine, but it's not cheap. So if we can prevent some of these things before they get to this point, I think we're going to be doing something incredibly worthwhile for our society as a whole, because we're going to shift the burden of expense to screening people. So again, I would emphasize where the action is or needs to be. It's not all of it, and I don't mean to say that. We still need the repair system, but we need to shift to putting much more emphasis on the community. And we just talked about workforce issues. There's a workforce that's available in East New York and other communities around the United States that are so-called disadvantaged, long underserved, whatever term you want to use. Many of them include men who have been incarcerated for the last 10 or 15 years, but are anxious to make a difference in society. But that's only one example of people who are available for this workforce. So let's get screening and educating today. As far as the government's commitment, we need to push for the government to get this screening program going. We're talking about the risk of the U.S. Preventive Task Force. That shouldn't be happening. We need to give more emphasis to this. So what we should have is the #1 healthcare system in the world, not the 10th. And I think we should be committed to making that change, and the government can help us tremendously in that regard.
Very much, Dr. Smith. I appreciate your remarks. I'd like to welcome Tamara next. She's an industry leader who's been dedicated to establishing authentic partnerships and executing meaningful initiatives together with patient advocacy groups and medical associations. Tamara joins us today to share how early disease detection is important to researchers and industry, and how Bayer has been able to utilize patient insights about early disease detection to expand their research and to better inform their kidney product development pipeline. Tamara is well known to the kidney community for her deep empathy for people who suffer from chronic disease, and she has keen insights on how early detection impacts research and development and creates greater opportunity to aid all people in need, both here in the United States and around the globe. Tamara, I'll turn it over to you.
Thanks, Ed. And thank you to the American Association of Kidney Patients and to your staff as well, Paul, Diana, Jerome, everyone. I really appreciate being here. It's an honor to be alongside Dr. Smith to speak with all of you today. You know, it's a really exciting time for research and innovation in the field of kidney disease. Today, patients have a wider array of choices and options for slowing the progression of kidney disease than ever before. These treatments not only reduce the risk of kidney function decline and kidney failure, but they also reduce risk of cardiovascular death and hospitalization for heart failure. Dr. Smith shared a few statistics with you, and I'd like to add to that because I believe it bears repeating. To know that I ask you all to consider that chronic kidney disease causes more deaths each year than breast cancer or prostate cancer. And this is a health equity issue. Minority populations in the United States bear a disproportionate burden of kidney disease. As Dr. Smith said, Black or African Americans are 3 times as likely, and Latino or Hispanics are 1.3 times more likely to experience kidney failure when compared to white Americans. And an estimated 37 million adult Americans have chronic disease, but approximately 90% of them aren't even aware of it. I mean, how can you do anything to help slow the progression of a disease you don't even know you have? And there's ample evidence, and there's multiple clinical guidelines recommending annual screening for kidney disease in individuals with diabetes and hypertension. But this screening is not routine. And so without widespread understanding and action, the status quo perpetuates, and chronic kidney disease remains an under-recognized public health crisis. So it's crucial for policymakers to recognize that their constituents are advocating for change. Leading kidney patient and professional organizations have united on this issue and are speaking with one voice. For instance, last year, with congressional sponsorship by the chairs of the Bipartisan Kidney Caucus, Representatives Del Bene and Bouchon, Bayer convened an educational briefing that included leaders from the American Association of Kidney Patients, the American Society of Nephrology, the American Kidney Fund, and the National Kidney Fund. The National Kidney Foundation. I'm used to saying all of these things in acronyms, but I'm trying to get away from the acronyms too, right? So the discussion really focused on creating equitable kidney care and breaking down existing barriers to upstream screening, diagnosis, and treatment. And all of this was underscored by the lived experience of our friend, platinum recording artist and kidney health advocate, Freeway, who shared his personal journey with kidney disease. He's an amazing patient advocate, and if you are not aware of him, I urge you to look him up. Following this briefing, the Kidney Caucus called upon members of Congress to sign on to an official letter addressed to the Agency for Healthcare Research and Quality and the U.S. Preventive Services Task Force, USPSTF, urging them to adopt a federal screening recommendation for chronic kidney disease. And partners took action, mobilizing their communities and engaging in outreach and numerous meetings with members of Congress and their staff. And in addition to the advocacy groups, Bayer employees themselves took action. Over 900 letters were sent to members of Congress urging them to sign on to this bipartisan letter. Additionally, Bayer recently hosted a panel briefing for legislators at the Women in Government's Leadership and Innovation Summit, where leading patient advocates and experts emphasized the impact of chronic kidney disease on our public health systems and the critical importance of early detection as a political priority, not only for federal legislators, but also state. And so in closing, early and routine testing for kidney disease can potentially save lives and improve patients' quality of life. The ripple effects extend to additional research and development opportunities, potentially revolutionizing innovation and clinical trial enrollments if more people can engage earlier, simply because they're aware of their kidney health status. However, as we continue these discussions, people are progressing in the disease unknowingly, leading to genuine and avoidable suffering and costs. Policymakers should be aware that there's a vast solution-oriented community ready to roll up their sleeves and collaborate to benefit patients. Because at the end of the day, it shouldn't require a trip to the emergency room with end-stage renal failure to find out that you have chronic kidney disease. And Bayer remains committed in standing with the kidney patient and professional societies that are continuing to lead this effort along with AAKP. So, thank you.
Thank you very much, Tamara. And I encourage everyone here and everyone online to look at Freeway's story, because he just covers the full gamut of kidney care, from crashing into dialysis and even sort of he admits an unhealthy lifestyle, up to finding out he had kidney disease, crashing into dialysis, undergoing dialysis while continuing to tour, getting a transplant, and then living his best life now and giving back to the community and making a difference. And I was fortunate to meet him through Tamara, and it's been a blessing in my life as well. So thank you, Tamara. Thank you, Dr. Smith, for your remarks.